very weird. I'm gonna share and then stop sharing. I don't know what's annoying. I cannot, this is strange. I had it open for some time. You do not see my screen, I assume. I can even not.
Good afternoon, Professor Philip. Could you share screen, please?
Yes, I'm trying. That's the issue. I cannot. Here it is PowerPoint. I didn't have it. I stopped, closed. So if everything is
Yes.
Okay, Philip.
good now, you should.
Okay. That's fine, but it could be better. You can.
They should
Yes.
be.
Okay, sir.
Okay, so I do apologize for the slight delay. This is my conflict of interest. I'm radiation oncologist. I work in Antwerp, and again, thank you very much for giving me this opportunity. A short introduction about re-irradiation. Re-irradiation in general has been the topic of a thematic issue of the journal Clinical Oncology, the UK-based journal. And of course, it started with an overview, which is not specific for breast cancer, but for cancer overall. And they clearly described that a decision on re-irradiation should take into consideration a number of issues. So first of all, the localization of the second tumor in relation to the initial radiation therapy, and thereby the previous exposure of organs at risk. Parameters of the initial radiation therapy, dose, fractionation, volume. Combination therapy, has the patient already had chemotherapy, biological treatments, and the time interval. How much time did go by between the first irradiation and now the indication for the second irradiation? And subsequently, we have to individualize. History and physical examination is very important. As the patient's symptoms related to the radiation therapy, how is the quality of the skin and the subcutaneous fat, is there recovery of hair? So that already defines how much the patient might tolerate for a second course of radiation therapy. And of course, we look into the technical details as well, not only the technical, but also the description of how the past radiation therapy went. So individualizing is especially for the time interval, and of course the benefit and the risk. And there, yeah, we are human beings. Is the glass half full? Is it full? Is it empty? And that defines your approach. So if you look into the field of radiation oncology, I know colleagues who will never re-irradiate, and I also know a lot of colleagues who have a very low threshold for re-irradiation. So those who consider it rather as it is an empty glass, it is, for example, a patient who had Hodgkin's lymphoma in the past, had a low dose of radiation received, has a breast cancer induced to the radiation therapy, but it's not completely within the fields. So that might be a patient which is excellently suited for a second course of radiation therapy. Other patients with a short interval and a high risk for complications close to the spinal cord, for example, it might be more risky to re-irradiate, while most of the patients will present with some options, but also some indications to be careful. So, as I said, the Hodgkin lymphoma 20 years before, you can re-irradiate somebody who had full course radiation therapy 2 years before, and then as extensive local regional progression is a completely other story. And what we see sometimes are patients who have had breast conserving therapy 10 years ago. Now, nowadays, we do not consider them automatically as being condemned to having a mastectomy. Some patients might be treated with second breast conserving therapy, and here we have to strongly individualize. So it's about philosophy. Is the glass half full or half empty? So if the glass is empty, it's clear. It is define the indication, prescribe, do the target volume contouring, plan it, evaluate it. It's a little bit business as usual. For example, the Hodgkin lymphoma patient. Then if it is a patient who has had recent extensive radiation therapy, aggressive course, you can try to make the indication, do the contouring, treatment planning, and you will discuss it with the patient, but often it is a compromise, and often it is considered as not being optimal to re-irradiate. And then the optimistical approach in the half full is the same story. You always define, is there a reason to irradiate, what kind of irradiation is needed, the target volumes, treatment planning, evaluate it, and shared decision making. And then often the patient, based on the information that we give, will accept, knowing that there is a higher risk for side effects. And then of course the pessimist, they have the same information, but they will rather have patients that decline because of fear for side effects. It can be the same patients depending on who is their doctor. So it depends, of course, on former experience as well. So chest wall recurrences is a well-known indication for re-irradiation. We published this in the ESMO Essentials for Clinicians a couple of years ago. I saw a lot of those patients when I worked in Tilburg, because we were a regional hyperthermia center. It is an excellent indication for hyperthermia. But we see that after mastectomy, rates of local recurrences in low-risk patients of 11% after 5 years, 26, 50 even after radiation therapy, still 14% local recurrences after mastectomy. We don't see those rates anymore. Now in mastectomy without radiation therapy, early stage disease, we see in those without nodal involvement only about 2%, and with nodal involvement 3% chest wall recurrences. Most of them, however, have an isolated chest wall recurrence. So on the other hand, of course, what's the clinical relevance of those recurrences? Now, we know that there is a relevance, because patients who have a local recurrence, regional recurrences, fare worse after being treated for those recurrences. But systemic therapy has a sharp influence on the occurrence of recurrences, and once they are there, on the subsequent course. So how to treat the breast or the chest wall after former treatment? There is no standard approach, that's clear. Don't condemn, for example, all breast conserving therapy patients who have a local recurrence to immediate breast mastectomy. There is no standard. See how you can individualize. What's the prognosis? Based on, of course, the disease, the therapeutic options, but also the performance status of the patient. How good is the patient? What is the life expectancy? The time interval between the two treatments, the side effects of the original treatment, and you can consider re-irradiation of the chest wall, for example, if the patient cannot have surgery for macroscopic disease for palliative reasons, for microscopic disease after resection, or after systemic therapy as well. If you have a complete resection, no risk factors, no need for re-irradiation. If the patient did not have radiation therapy before, of course there is a clear indication. If you have risk factors, consider if the patient has a good prognosis outside of those recurrences, tumor biology, systemic therapies, and comorbidity. If the tumor the recurrence on the chest wall has been microscopically incomplete, resected, then strongly consider the re-irradiation if there is no disease elsewhere, the patient is not having metastatic disease. If it is a high-risk tumor, you have less options for systemic therapy, and if the patient tolerated the initial radiation therapy very well. Macroscopically incomplete resection, consider it depending, of course, also on the complaints and the options for systemic therapy. And for palliative treatment, yes, unless there are other treatments available, there is doubts. An ulceration might also be a complication and not tumor progression. And if patients have very short life expectancy, unless, of course, for pain or bleeding. So I advise you, these essentials for clinicians are free for ESMO members. It's all in there, and it's, of course, just one of the chapters. Hyperthermia, I will not go into details. Hyperthermia also developed as a subspecialty. It's often combined by radiation therapy. There are prospective studies that confirm that radiation therapy alone compared to radiation therapy with hyperthermia, that the complete response rate and the enduring of local control is improved with hyperthermia. But the hyperthermia is critical. It has to be given within a short time frame of the radiation therapy. So if you give the hyperthermia here and you give it concomitant with radiation therapy, you have a higher effect on the tumor, but also a higher effect on the normal tissues. Optimally, you should give the radiation therapy 1 to 4 hours, the hyperthermia, and then the radiation therapy 1 to 4 hours before or after, in fact. And then you have no enhancement for the complications and a clear enhancement for the tumor effect. Hyperthermia is defined and it's about 1.4 enhancement of the radiation effect. This is a nice example of a patient who had recurrences around the scar, and up to years later she did not recur. We compared a lot of patients together with other centers with hyperthermia, 583 patients from 2 centers with macroscopic disease, so these are really poor patients. Mean tumor size was superficial, of course, it was not in diameter, but in diameter, superficially spoken, 10 centimeters, about half at regional disease, contralateral disease, some distant metastasis, and these were the schedules used. In general, hyperthermia is given once or twice a week, and 82% had a clinical complete or partial remission. Only a minority of the patients did not respond at all to the radiation therapy with hyperthermia. If you see the lasting effects, but mind, this is macroscopic disease, mean diameter was 10 centimeters. At 3 years, still 20%, so that's 40% of those who had a response have enduring local control, and in most of those it remains for the time of their life. Okay. I went too fast. Okay, multivariate analysis. What is of importance is the size of the recurrence, the time interval, the number of recurrences. Unfortunately, patients are sometimes even only referred after they had their 3rd, 4th, 5th recurrence, distant metastasis, and contralateral disease. So don't wait too long with referral because it increases the burden to the patient. There is a high response rate, it is durable, size is important, and other prognostic factors are the traditional ones, including earlier treatments. So therefore, we need to start earlier, give it also electively in high-risk patients. We did a series with them after salvage surgery, so with no macroscopical disease, And at 3 years, 78% had local control, and most of those did not recur ever. We might combine it also with systemic therapy or with other sensitizers. Higher radiation doses, we are reluctant, but we can for sure optimize the hyperthermia delivery. For recurrent breast cancer, we are speaking now for really very palliative reasons. Patients who have very extensive disease, they are not seen often anymore, thanks to improving in everything, diagnostics including treatment. Sorry. The objective here is clear: local palliation as long as possible. And we had at least stable disease in 2 patients out of 3 for at least a year. In ulcerating tumors, even, it was 61% with a complete or a partial remission. And only 9% of the patients who had tumor ulceration developed a treatment-related ulcer. So it's not so toxic. What is prognostic here? The size again, the time interval, ulceration. In general, ulcerative tumors respond less good. Concomitant chemotherapy. And for the progression-free survival, again, the ulceration, prior chemotherapy, concurrent chemotherapy, and the lymphangitis. Lymph node recurrences is another story, because there it's not superficial, it's deeply seated, much more difficult to treat combined with hyperthermia. But what we see to start with is that most recurrences occur within the target volume. So if the patients had irradiation before in the primary treatment, it's nearly always within. In this Danish series, only 1 patient had a recurrence outside of the contour target volumes. Where do we have to take, what do we have to take into account? The proximity of the spinal cord and the brachial plexus. If you have nodal recurrences, it's often in this region. Spinal cord is less often a challenge, but the brachial plexus can be. And the current doses, the limitations that we respect for spinal cord and heart and brachial plexus are well described and known. So we have to respect this. We can calculate based on radiobiological experiments of the past that we can take into account some recovery over time. Second breast conserving therapy, an example after Hodgkin lymphoma. We know that patients who had treatment for Hodgkin lymphoma at very young age, they have a risk for subsequent breast cancer that is as high as a BRCA1 carrier. This is an example of a patient that had a mastectomy with axillary lymph node dissection for 7 nodes positive breast cancer. And she had an immediate breast reconstruction, and we treated with multiple fields only the draining lymphatics because the implant is not part of the target volume. She never had a recurrence in the several years that she survived, but unfortunately she developed distant metastasis. So this was in 2010, quite some years ago. Second breast conserving therapy is also after earlier breast conservation. So a series from France, 2/3 of the patients had a mastectomy, 1/6 had a lumpectomy with brachytherapy, and 1/6 had a lumpectomy alone. And the results showed that mastectomy is equivalent to lumpectomy with brachytherapy in this series. A lumpectomy alone without supplementary irradiation was inferior. A bigger series, because it concerns many more centers, from Jack Estro, included more than 200 patients with a median follow-up, a time interval between the, for the primary 14 years, for the recurrence 3.9, and the second local recurrence was only seen in 4.1%, in fact less than distant metastasis. So the actuarial second local recurrence rate was only 7.2% at 10 years. That means that after second breast-conserving therapy at 10 years, more than 90% did not have, again, a local recurrence. And most of the recurrences occur again at the same place. The primary tumor, the first recurrence, the second recurrence. The primary tumor, the first recurrence or new primary tumor, and the second recurrence. And some patients also had the second recurrence at the site of the original tumor. Late effects are frequent, fibrosis, telangiectasia. However, for the big majority, they were not severe. So, bringing this into summary, a discussion, what is the role of staging? If there is still a place for local regional treatments in the case of metastatic disease, we now know oligometastatic disease as a separate entity, depends on the tumor type, depends on whether or not you can give systemic therapy. Breast-conserving therapy or mastectomy after local recurrence is the standard approach. So you have breast-conserving, you have recurrence, standard approach is mastectomy, but we wonder, can't we do less? So a second lumpectomy alone might hide second local recurrence. So this is not enough. Second lumpectomy with irradiation gives, which is progressively more used, seems to become the second standard approach, but I advise to do it within the framework of clinical trials. Irradiation for chest wall recurrences is standard, but often second recurrences are seen, and therefore combined with hyperthermia, it is better. And this is a standard approach, however, not available in many countries. This is an overview that has been published. Also, photodynamic therapy for chest wall recurrences is an option if available, and there might be other alternatives as well. But the most important are target volumes. If we speak about target volumes, this is a trial, an NRG trial of the US, with, about second breast conserving therapy, and they describe the target volume as the surgical cavity. This is absolutely not a target volume. The target volume has nothing to do with the surgical cavity. So do it right if you do it. So, concluding, local regional recurrence rates after radiation therapy are much less frequent than in the past. If you have a patient with recurrence, evaluate her carefully, physically, and also physiological and radiobiological. Re-irradiation is often a component of curative intent treatment. Addition of hyperthermia to re-irradiation for chest wall recurrences is a standard. Second breast conserving therapy is an emerging standard, but please register and participate to trials, and you need to select the patients very well. Multidisciplinarity is key to be able to individualize and not perform a mastectomy even before the rest of the team has discussed the patient. Systemic therapy can further improve survival, properly combined with local regional treatments. And in general, we can say for isolated regional recurrences that the 5-year overall survival now is around 50%, which is much higher than in the past. And again, it's about patient selection that has to be fine-tuned. These are the people I would like to thank in this framework, and thank you very much for your attention. Mm-hmm.
Thanks, Professor Poortmans, for this highly informative presentation about re-irradiation in breast cancer. Now we can open the floor for the discussion or questions. Do we have questions? Okay, any question from chairpersons?
Yes. Just comment, please, Dr. Philip. what, in your opinion, optimal interval between primary radiotherapy and re-irradiation?
I understood primary radiation therapy and re-irradiation. What would be the optimal time?
Yes.
Okay, the longer the better is a general principle, but you have to individualize. If you have a patient who after 2 years has full recovery of the skin, you don't see any secondary effects, the risk for her will be lower than in a patient you see after 10 years but has telangiectasia, a very thin skin, no subcutaneous fat, etc.
Yes.
General principle, the longer the better. There is no absolute minimum, but in general we say a year will give a recovery depending on the tissue between 30 and 50%.
Okay. And what about maximum dose I can reach?
Well, if your original dose that you can deliver, for example, the skin can have, with acceptable risks, 65 to 70 gray. You give with breast irradiation 40 gray, because you give 50 gray equivalent, but the skin doesn't get a full dose. So you give 40 gray. There remain still 25 to 30 gray. If you wait a year, you have about, for the skin, nearly 50% recovery. So you can add up 50%. So you arrive in between 30 and 37.5 gray. So that way you can individually per organ and for the interval estimate the residual dose. And if you add up then the total doses, you're much higher than if you would give everything in one time.
Okay, thanks a lot.
Thanks, Professor Poortmans. We are running out of time, and I think we don't have no more questions. Now I'm going to proceed to the next speaker.
Okay. And now we move to our next speaker, Professor Joseph Prof, and very, very interesting subject. What about systemic management of lymph?